how do you do pedal loop? I mean, that's a big question. What's the technique? It's a little daunting when you think about it, but let's just kind of go over what you do, and what other kind of tips you can give our listeners. So, you can start from your access and devices and things like that.
So yeah, I think that's a great point. I think when you're entertaining tibial pedal at all, or pedal intervention, as most of my patients, I think your approach matters more than anything else sometimes. And the approach is, for me, if possible, integrate access on that same groin. I think what we learn is that the shorter the distance to treat, the better success you have with your tools, the support structure, the less length of wires and catheters. If your patient's close to 6 feet or above, you're going to have trouble up and over to do a pedal loop, because getting sufficient wire purchase, catheter purchase, balloon length, the majority of products out there are tough to do from an up and over approach in through the pedal circulation. So if at all possible, always integrate down that same leg. Now, part of that is knowing what the inflow is like. And that needs to come from either non-invasive imaging that you have, your physical exam combined with that, or some people do CTAs, or they have a prior diagnostic angio. Some people will do a radial access to shoot it and then go from there. One thing that we'll do every now and then, or whenever we feel appropriate, is we can flip the sheath. And we've talked about that before in other situations where you get that same side access, you go up to check everything, and then you come flip the sheath and you go down once you're satisfied with what it looks like. So access integrate's great. The Panis retraction system, not sponsored by them or anything like that, but that's been a game changer for the Midwest Panis for me. There's patients who have Panis down to their mid thighs, but on the table, I can't see any Panis. And that thing, it makes a world of difference when you're doing integrate access, because you want safe closure or, hemostasis, and that Panis is nothing but a danger zone if you don't get it out of the way. So good prep, and that involves having good discussion with your techs and team to get the Panis out of the way, integrate access. You can watch under ultrasound to make sure you're going down the SFA, get a sheath down. And then from there, for me, usually I'm always in an 014 system when I'm going down below the knee. I don't play with the 018. I'm going to end up in the 014 because most of the patients have end-stage renal, diabetes, their vessels are small, they're calcified. 018 for me, below, mid or below the tibs is not going to get anywhere. Then the question always comes about pedal retrograde access. There's a lot of operators or increasing operators will do primary pedal, which for me, it's a little tough because I need to see the above access and flow first. And I like the support because half the time I'd say I'm snaring something. So having that access from above for me for tibial-pedal disease, I need 2 accesses at the minimum. Nowadays, I think having the extra tibial access or pedal access is probably in the range of 50 to 75%, somewhere in there, of cases that'll have some additional adjunctive access. And for that, I don't use sheets. I don't know about you. For the pedal access, I just use the wire and inner of the micropuncture sheath, the inner 3. And then if I do a catheter, it'll just be barebacked.
Yeah.
A lot of people will put a tibial, a radial sheath, slender sheath, and then if you're going to do that, radial cocktail. But for me, I'm not doing the interventions from below. So really, I just need it as an access point. And I still have to reverse to go my wire, my intervention past that access point. So the less I have in there, the better for me. And I think a lot of us consider operating that way. But for the loop part, I think things that help is a patient that can remain still. And I think that's probably the bane of many of our assistants.
It's huge.
So having a patient keep their foot still is critical. And whether that be they're just really good, they have no sensation in their foot, or you have general anesthesia, I think those are things that are going to really help you. I wouldn't entertain doing complex pedal work or a loop in a patient that's just restless leg or moving or just in pain.
Impossible.
And I think part of that, maybe too, maybe you've seen this, is part of their mindset of that discussion with the patient. I can remember doing some cases scrubbed in Leipzig at Link Hospital. And I remember asking the physician I was with, we were scrubbed in, I go like, what's the sedation protocol? He goes, what sedation? And they give just lidocaine. And the patient was like a rock. And this is not just one patient, multitudes of patients that I saw that day. And the patient had some mild pain in the SFA. So he just tumescent some lidocaine around the SFA directly through the skin. And I was like, this is unreal. But he said, part of this is when the patients know what's coming or they know what they're going to get, that's it. I think we have a little bit of trouble here with that, anesthesia for a PICC line. So I think that's part of the thing is having a patient that keep that foot still, because for tibial-pedal interventions, I'd love to hear your talk on this, but I use a lot of the DSA road mapping.
Mm-hmm.
So when you do that direct injection from the pop or pedal vessel, tibial vessel, where you get that path where you might want to go, having that foot still with the DSA roadmap really helps for me kind of decrease the contrast. I can watch where I'm going. That helps a lot. Heavily calcified patients, sometimes you can just watch how you're going under the fluoro. EVIS is another way. If you have somebody else to help hold you while you're manipulating this, Giada Fadi and them love showing that. I think it's a great adjunctive tool if you have somebody else to hold the probe for you and kind of do that. I don't do much EVIS for that, but I think DSA fluoroscopically is more than enough for most cases for me. Navigating that loop is tricky, especially on the lateral view. You've probably seen that. You're seeing and you're trying to find where that actual plantar loop is towards the TMA site, that TMA level, and then navigating it. I think some of the hardest parts are getting your support systems across that area, especially when they're calcified, because you get these kinked areas of calcification. That becomes a little bit tricky. So for me, it's the antegrade access, adjunctive pedal access, and then going around the loop with DSA roadmap, either general anesthesia or a patient that's not moving. If the patient's moving on your procedure and you can't add anesthesia at that point, that's a situation where I'd say reschedule it.